first of all, thank you to Dr. Zed, Dr. Zuri, and all of the Warrior Docs for having me back on. I'm always humbled and grateful to be able to share these Warrior webinars with you guys. I absolutely love this stuff. I'm a bit of a spine geek, and so I'm glad when there are doctors who are willing to listen and apply some of this stuff in clinical practice to always get, again, as doctors both Ed and Yuri mentioned, better clinical outcomes, better outcomes from our patients, and have them stay on long term, because that's the goal, right? We know that we get our best results over time and patients do the best over time. So I'm super happy to be here today. I was just looking in the chat on the side here are the names, and I see a lot of familiar names from previous years. So those docs who have been on year after year and following, thank you for being on and paying attention. And you know, if you've been on these for a long time, they're always building on each other. So it's going to make more sense to you if you've seen the previous webinars. If you're not a Warrior Doc or you haven't seen the previous Warrior webinars, get in touch with Dr. Zed and Yuri both, and let's get you access to those previous webinars so you can have that foundation and continue to build. So some of the concepts that we talked today about are going a little bit over your head. I'm not going to dive into detail about a lot of the measurements that we're going to discuss because we've covered them in previous webinars, okay? So if some of the stuff is 37,000 feet, that's okay. The big idea today is to understand that spinal surgeons share a lot of the same interests in correcting the spine as we do, okay? So let's dive into this. So first of all, I want to give credit to where credit is due. So Dr. Evan Katz, he's a chiropractor in Colorado. He does a lot of work with patients who are in car accidents, personal injury cases. And so a lot of this research I grabbed from his website, which is professionallyintegrated.com. And so he has a service. One of the services is free. He has a few different levels of paid service depending how much detail you want on these articles. But he is someone that combs this research. He goes through this research and he has it in this really nice database format that you can follow. And it is obviously geared towards injury stuff in the US, but the reality is it applies to everything that we do as corrective care chiropractors. So I want to give him credit because, you know, I wouldn't have known about these articles had it not been for him. He's a CBP doctor. And if you were on the webinars last year, he was the one that did the MRI study. He rented out a private facility himself and, you know, put dental rolls under patients' necks to see how well the blood flow to their brain improved while they were in the MRI machine with a dental roll under their neck. Furthermore, Evan Katz has volunteered to be an expert witness in this battle against the BC board to protect our x-ray rights, right? As we all know, there's some dimwits in our profession who unfortunately want to remove our rights for the biomechanical assessment of the spine, saying that there's no science or data to support the fact that we should be taking x-rays for biomechanical reasons and reconstruction of the spine. And this is likely some of the stuff that Dr. Katz is going to be using to battle against these chiropractors who are naysaying the benefits to reconstructive surgery or reconstruction of the spine, okay? So again, let's get into this. So some insurance companies, providers who are saying we shouldn't be doing reconstruction, that we should only be adjusting people for pain. And these surgeons are getting compensated a ton of money to put curves back into the spine, to fix the spine, things that we can do for an absolute fraction of the cost with the added benefits of obviously getting these patients adjusted. So understanding this science, understanding this, and taking some notes today and putting some of these notes in your daily soap notes is not only going to help you be an expert, but help you, like Dr. Yuri mentioned, communicate to your patients to keep them on long term. So let's get into it. We're going to cover 3 articles today. This is only the tip of the iceberg. Again, if you start diving into this, there's article after article, because this is truly an area of extreme interest, and it's a hot area in the research right now for spinal surgeons, okay? So I cherry-picked 3 articles that I wanted to go through with you guys, and these are not just mom and pop journals, right? Neurosurgery, Journal of Spine Surgery, Journal of Neurosurgery Spine. These are top-tier journals from, what's considered in the spinal world. I wish it was chiropractors who were at the height of the pyramid or the top of the food chain, but the reality is it's neurosurgeons, right? Spinal surgeons. And this is some of the stuff that they are saying and that they are researching. The same things that CBP has been promoting for the past 35, 40 years, these spine surgeons are now taking an interest to do the exact same things that we are trying to achieve with our patients, okay? The first article, in a nutshell, they are saying lordosis after fusion gives better outcomes. what these surgeons were looking at was when they do a discectomy fusion, right? So these patients come in, they have neck pain. For whatever reason, they are deciding to do surgery. Oftentimes, it's patients who do what, they'll consider 6 weeks or 6 months of correct conservative care. These patients fail conservative care. They're still having neck pain, or, they might have some disc issues, disc problems. So they deem that they're candidates for cervical surgery. And so these surgeons were looking as to whether or not the shape of the allograft that they put in between the bones would change how much curve they could put into the neck, and would change the outcomes for these patients long term. Okay, so they were comparing what they call lordotic allografts versus parallel allografts, which means absolutely nothing for us. So it's a detail that we're not concerned with. I'm just explaining what these surgeons were doing. And they were, again, the most important part was looking at what was that result in terms of curve correction, and what was the result in terms of patient outcomes when they were using these different types of allografts to fuse these patients, okay? So these are just some of the highlights from the article. They're saying, although it is generally accepted that the physiological sagittal balance is important for normal function of the spine, whether maintenance and improvement of the cervical and or segmental lordosis have an effect on clinical outcomes after surgical spine surgeries remains to be proven, right? So this is back in 2011. This is, some of the hypothesis. This is the questions, the introduction in this article stating, is there a benefit to putting the curve back into the spine? Is there a benefit to looking at the alignment of the cervical spine? What these surgeons did, right? They did assessment preoperatively and postoperatively. They looked at CSA, which stands for the total curve in the neck, and segmental sagittal alignment, what we would call intersegmental subluxation. So they were looking at the curve between individual bones, and they were looking at the curve, the total curve in the spine, right? Now, I'll just take a minute. And the reason I highlighted this in yellow is because these surgeons took an x-ray before they're going to work on the spine, and they took an x-ray after they worked on the spine, right? Do you think these surgeons are being reported to their boards? Do you think there's a battle within the neurosurgical profession where some of their colleagues are trying to get x-ray rights removed so that they cannot x-ray their patients after they've done something? Absolutely ludicrous to think that, a surgeon or any health professional that's going to be working with the spine doesn't want to see, number one, what they're working with, and after their intervention to see how well did my intervention work, and did this intervention correlate with long-term health outcomes on our patients. This is no different. This should be absolutely the very same thing for us. We want to see what we're working with once we're done our work, or incrementally throughout our work, because we're never done our work. Incrementally, we should be checking up to see how are these patients doing, what does their spine look like, and does that correlate to how well they're doing, okay? These surgeons measured the spine using the posterior tangent method, which is exactly the same things that we do with our patients, okay? Sec here, where's my mouse? Sorry guys, give me one sec here. All right, so lordosis after fusion gives better outcomes. So again, what these surgeons were saying here is it was determined that the maintenance of or change in SSA, stands for segmental sagittal alignment towards lordosis, was an important factor responsible for a higher degree of improvement in clinical outcomes after single and multi-level fusions. In our investigations, patients who had the change in SSA towards lordosis demonstrated, sorry, let's go back one there. Sorry, guys, having a little technical difficulties with my mouse here. They were saying the patients that had the change in lordosis in their single and multi-level fusions had better improvements in neck disability and overall quality of life scores. So what does SSA mean? Again, it's segmental sagittal alignment. So they're looking at the alignment between two individual vertebrae. So for instance, we could use C4 and C5, right? They're saying the patients that had a change when they fused them towards a lordotic position had better results in terms of neck pain and quality of life scores, right? And in total conclusion for this study, they were saying that maintaining a consistent or improving the segmental sagittal alignment was related to a higher degree of improvement in clinical outcome scores. So their hypothesis at first, they were looking as to whether or not it was important to look at segmental lordosis and total lordosis and look at the alignment of the cervical spine. And in their conclusion, maintaining a consistent or improving the segmental alignment is related to a bigger degree or a higher degree of improvement in clinical outcome scores, right? And I want you to look at the words that they chose in the earlier statement there. They mentioned that they demonstrated a significantly higher degree of improvement in clinical outcome scores. So they're not saying it was a moderate change. They were saying it was a significant change, okay? This one is a second article. This is out of the Journal of Spine Surgery. And this was a review article where they were reviewing the literature to say, you know, as surgeons, do we know enough to create successful spinal surgeries? Should we be looking at curves? Should we be looking at alignment and positioning? Okay. And so this is very similar to what the Harrisons did at first when they were looking at putting a curve into the neck. At the very beginning, when they came up with their cervical models, they were thinking that everybody should have that ideal 42-degree arc in the neck, right? And as time went on, they started to realize that, well, maybe it shouldn't be a 42-degree curve for everybody. Maybe there is some genetic variability. Maybe there are other things that we need to consider and not just put a curve back into the neck. So that's what this article largely stated. Okay, so here are some highlights from the abstract. Over the past decade, there has been growing interest in the sagittal alignment of the cervical spine and its correlation to clinical outcomes. It is now known that the cervical lordosis is not universally physiological and should not be pursued in all patients undergoing surgery. Okay? Rather, it is increasingly understood that it is how these angular parameters, lordosis or kyphosis, interact with translational parameters that is reflective of overall cervical spine and whole spine balance, which in turn impacts patient outcomes, okay? In simple English, they're saying that we can't just simply slam a curve into a neck. We have to understand translational parameters, which again, last year when we did our cervical reconstruction, we talked about translation and how when the spine shifts forward, backwards, these shifts in the spine come with biomechanical changes or compensatory patterns. And we have to look at those patterns. We can't just fuse someone in a bad position with a neck curve. Like if their head is way forward and they got a really strong kyphosis, if I put a neck curve in, you know, that's better, but it's not a great outcome. There are other things to look at. People that have very low pizza angles or very shallow thoracic inlet morphology are never going to have great curves. And we have to be very careful that we don't put too much curve into their neck. We want to fuse their neck, or we want to achieve the proper alignment for that patient's spine. So what these surgeons are saying is it is not just putting a curve into the neck, it is multifactorial, and we have to understand the biomechanics, the dynamics of the spine as a whole before we do our intervention. And the same goes for us as chiropractors. We can't just simply try and ram a curve into the patient's neck. We need to look at translational parameters. We need to look at the thoracic kyphosis, the lumbar lordosis. We need to look as to whether this patient is shifted forward, backwards. Is there degenerative changes? And so all these things need to be taken into consideration to understand what that patient's normal should be and what we are looking for in terms of our reconstructive outcomes. Now, here are some of the x-rays that they had highlighted in this article. Now, we don't have a full background on this individual patient, so we're not going to judge the spine surgeons and say they did something that should not have been done. But what I want you to notice is, yes, this patient had a cervical kyphosis. Now this patient has a lordosis, but at the expense of what? 1, 2, 3, 4 screws, 2 metal rods into this patient's neck, loss of mobility, adjacent segment degeneration that's going to happen for sure at C1, C7, C6, right? And so yes, this patient now is probably better off because they have a lordosis in the neck, and this patient will fare better than maybe they did with this kyphosis. But how? How can someone argue that if this is reasonable and acceptable for a patient to undergo a surgical intervention like this, that it is not reasonable that this person undergo, multiple phase stages or years of corrective chiropractic care to try and achieve and maintain a lordosis in their neck to not have to have a 4-level cervical fusion, right? Again, completely ludicrous that we are that we're judged or that we have professionals in chiropractic who are trying to remove these rights from us and are arguing that this is not valid. It's crazy. Sorry if I'm getting a little fired up and stumbling on my words. This topic gets under my skin. So some of the highlights of this article again, over the past decade, there has been growing interest in the sagittal alignment of the cervical spine and its correlation to clinical outcomes. Early studies have focused on mainly achieving sagittal spine balance as determined by the sagittal vertical axis. So what they were saying was, at first, they weren't necessarily looking at curves. They were more interested in just fusing a patient in proper spine balance, okay? And again, we looked at this in the cervical spine, and I've gone through the sagittal vertical axis with you guys. We just use the terms anterior translation, posterior translation. But for a quick overview of what they mean by SVA is, when we're looking at the sagittal profile, so this is a sagittal profile x-ray, the vertical axis is going to be a reference point. So we could use, oftentimes they're going to use the sacrum. So they could put a dot somewhere on the sacrum, you know, anterior, posterior, whatever they choose for that study. Okay, so in this case, let's use posterior, superior aspect of the sacrum. And I draw a vertical line up. Now the reference points from there, sometimes it's C1, sometimes it's C7, sometimes it can be T1, depending on the study, depending how they x-ray and what they see. Now, what they're looking at, what they mean sagittal vertical axis, is they're measuring the distance in which the spine is shifting forward relative to that vertical reference point, okay? And we know there are boatloads of studies that show that the larger the distance between whatever reference bone they choose up here in the spine and the pelvis, the larger that value. So in other words, the further forward this patient translates, means a more positive SVA equals bad outcomes, right? Higher pain, higher disability, more fractures, more organ problems, right? More general nervous system dysfunction, more falls, and a higher rate of death, okay? So surgeons know it's important to address this with cervical fusions. Now they're saying, you know, should we also be considering what the curves look like and how do we implement curves with sagittal alignment when we're doing these surgeries? And I would say, I don't know about you guys, but I think this patient probably should have went under chiropractic care before going for this surgery. All right, so the other thing that I love about this, all right, so we have Dr. Pierre Cote, who writes this report or comes up with this study for the BC board saying that there is no evidence to support that corrective care, or there's no evidence in the literature, no scientific literature that supports doing corrective care and patient outcomes. So when he did his literature review, they did not use anything from the CBP library, none of the 240 plus studies that CBP has done. What's really interesting, though, is that a spinal surgery review article actually did look at some CBP work, and they did look at the Harrison's work. And so some of the stuff that they're discussing in this article, they actually reviewed CBP line drawing. They actually reviewed CBP modeling and the outcomes of care based on some of the work that we're doing as corrective care chiropractors. So, you know, for those chiropractors that are saying that that science is not valid, well, again, I'm calling BS, because now you've got a surgical article that's actually looking at the measurements and stating that, yes, this stuff should be considered, and yes, we should be using this stuff, okay? So here are some of the excerpts again from this article. A correlation has been reported between patients with acute and chronic neck pain and reduced cervical curve below 20 degrees compared to asymptomatic individuals. Another study showed that global cervical alignment correlated with health-related quality of life indices. You know, that alone, even outside of putting curves in, you know, how can you know what the alignment of the cervical spine looks like without taking an x-ray, without working on it, you know? And so we know that the alignment of the cervical spine is directly related, and that has been stated and proven over and over, to the health-related quality of life indices. A kyphotic cervical spine places the neck musculature at more strain when supporting the weight of the head, with increased pressures on the intervertebral discs, resulting in accelerated degeneration and worsening deformity. This finding is also highlighted in several other studies in which a kyphotic cervical spine predisposes patients to an increased risk of what? Developing pain, great, right? But what we're more concerned about, neurovascular deficit, including cervical myelopathy. That is a beautiful definition of subluxation right there. It is generally accepted that in patients undergoing cervical fusion surgery for a variety of indications, fusion in kyphosis, whether regional or global, should be avoided, as it is thought to lead to what? Increased rates of segment degeneration, adjacent segment degeneration, meaning the segments above and below will start to degenerate and degrade if the spine is fused in a kyphosis. And even if it's not fused in a kyphosis, if a kyphosis is just left in a non-fused neck, you're gonna see more rates of degeneration throughout the cervical spine. That's what the previous paragraph had said, okay? Now, restoration of the cervical lordosis allows optimal distribution of weight to the posterior column of the cervical spine and more efficient energy expenditure by the neck muscles. Mic drop. A commonly used translational marker for the cervical spine sagittal balance is C2 through C7 SVA. Again, what we discuss as anterior head translation. So this author here found that patients undergoing cervical spine surgery, their preoperative sagittal alignment correlated to the degree of reported disability. In other words, the higher the C2 through C7 SVA, aka the further their head translates forward, they had a higher level of neck pain or disability. Okay, while higher values of cervical lordosis, so the more curve they had and the more slope they had at T1 relative to vertical. And if you guys remember from last year, T1 slopes are referring to the amount of kyphosis. In other words, the more lordosis they had and the closer their T1 slope approximated their normal thoracic kyphosis, they had lower neck disability scores. Interesting, right? So if we decrease anterior head translation, right, and I drew the anterior head translation as I taught it to you guys last year, and we increase cervical curve, patients have lower rates of neck disability. Beautiful. Conclusion: cervical sagittal balance is undoubtedly a vital concept that must be considered with surgery to the cervical spine. Patients with preoperative cervical kyphosis with sagittal imbalance are known to have worse outcomes post-operatively. Okay, let's rephrase that conclusion in a chiropractic model. Cervical sagittal balance is undoubtedly a vital concept that must be considered with chiropractic care to the cervical spine. Patients pre-care with cervical kyphosis in sagittal balance are known to have worse outcomes, especially if we leave the kyphosis in their neck post, pain care. Last article we're going to discuss, fusion to improve the lordosis. I included this article because I wanted to show you that, the rates of correction that these surgeons are excited about pale in comparison to what you guys are doing every single day in your office. I can guarantee you that probably every single chiropractor on this call will see necks significantly worse than this and will be able to get better results than this patient could ever get in a cervical fusion. Okay, so these surgeons did the same thing. They call it an anterior discectomy fusion. So, they pull out a piece of disc material and they fuse two vertebrae. And their goal, these surgeons, their goal was to try and put a curve back in because, as they state here, right, that this type of surgery can be used to correct cervical kyphotic deformity, which is the most common cervical deformity and is often performed using lordotic interbody devices. Worsening of the cervical sagittal parameters is associated with what? Decreased health-related quality of life. There it is again. Boom. Over and over and over. The radiographic measurements that these surgeons use were focal lordosis, or what the other article had referred to as SSA, okay? What we refer to as the curve between two segments or intervertebral subluxation. Disc height, which we don't typically measure. I don't measure in my office. I just look objectively on x-ray to see if there are differences in disc height, if there are signs of degeneration. C2 through C7 lordosis, so total curve. They did C1 through C7. We don't. We just use C2 through C7 because it's easier to recreate. And they looked at the T1 slope relative to vertical, which we discussed again, is that indirect measurement of thoracic kyphosis. And lastly, C2, sagittal vertical axis, or anterior head translation. So those same four variables that we've been taught or that we discussed last year that we measure over and over to understand what's happening with the patient's neck. Now, here are their results, okay? So their pre-surgical curve was 9.66 degrees. At 1 year, this is what they state. The C2, C7 lordosis significantly improved at 1 year by a whopping 3.46 degrees. This is the kind of change that you can get in about 10 sections of laying on a dental roll, right? Without the complications of surgery. Yes, they had a nice intersegmental change. They took, a vertebrae that had zero curve, like this would be a vertebrae that's has 0 degrees of curve. And at 1 year follow-up, they said they averaged about 6.5 degrees, which is pretty close to the normal or ideal value of 8 degrees. So, intersegmentally, that's a great change. Globally, they get 3 degrees of change. Great. I'm happy that these patients are doing well. But again, we see necks like this day in, day out, and we could do this stuff for our patients at a fraction of the cost without any of the effects of surgery and all of the functional and neurological benefits of being adjusted. All right, I'm going to read this last paragraph from, again, this article, because this simply supports chiropractic through and through for any docs who are doing this type of corrective care, okay? So listen to what these docs are saying here. The ability to create and maintain cervical lordosis is an important step in optimizing overall cervical alignment and thus increasing the probability of obtaining excellent short-term and long-term outcomes. Again, another statement that completely supports what we're doing and what we are trying to achieve. How can someone negate something like this? I mean, this is 3 articles now stating this over and over again. Due to the increasing recognition of cervical sagittal alignment as an important indicator of cervical deformity, osteotomy techniques have been developed to gain lordosis and thereby improve cervical sagittal alignment. However, these lower cervical and upper thoracic 3-column osteotomies can result in significant complications. No kidding, when we cut open a cervical spine, there can be complications. So it would be best if each and every ACDF, so anterior fusion procedure, was performed in such a manner to minimize the likelihood that significant deformity will occur with time. In other words, they're saying when you fuse the neck with these anterior fusions, try and fuse them in a curved position, not a kyphotic position, so that these patients don't have to do revision surgeries later on, right? Osteotomies to decompress the spine and to try and put the curve, back into the neck, because those patients do worse if they're not fused in a proper position. So achieving this goal will decrease the need in the future for complex, expensive, and dangerous procedures in those patients who initially only require 1 or 2 level cervical fusions. Let's reframe that conclusion again. Achieving this goal will decrease the need, achieving this goal meaning cervical lordosis. So achieving a cervical lordosis will decrease the need in the future for complex, expensive, and dangerous procedures in those patients who initially only required corrective chiropractic care. Can I get an amen? So how do we do that? Exercise, adjustments, and traction, right? Exercise, adjustment, and traction, the EAT protocol. Exercise with our prolordotics, traction, laying on dinner rolls at home or in our office, and adjustments, the magic that you guys are making happen in your office every day. And with that kind of protocol, here's an example of what we can do over the course of a year without surgery, right? So here's an 8-degree curve, one of my patients, to a 25-degree curve by simply following that protocol over the course of corrective care with 1 year. 17-degree curve improvement, no surgery, no complications, right? So, this is the last slide I had for you guys in terms of x-ray correction. So I hope that, you guys are going to take away this message here. We're going to agree with the ACA, right? Choose wisely. Let's not take x-rays and only adjust our patients 4 times for pain, because there is no benefit above that, right? I hope you guys know I'm being facetious. What is wrong with some of the people in our profession? So again, thank you for being on this webinar with me.